All right, you guys are live.
Hi, everybody. Welcome to our seminar. See people coming in. We'll give everybody a few minutes to get connected. Welcome, everybody. This is our first ABS webinar for gynecologic cancers. And we're going to be talking today about hybrid applicators, something that I think many GYN brachytherapists have either been thinking about or using. And they present some new and different challenges. So I'm really looking forward to getting feedback from our panelists today. So we have Dr. Chino from Duke, Associate Professor of Radiation Oncology and the Director of Brachytherapy, and Dr. Scott Glaser from the City of Hope, who's the Director of Brachytherapy and Gynecologic Cancer Treatment. And so our plan for the seminar today is to present 3 cases, and we'll do a little background. Dr. Chino is going to start off, and then Dr. Glaser, and then myself. And we'll present cases, and we will take questions in the Q&A box. So encourage everybody to send your questions. I'll be reading through them and asking them. And I hope we have lots of great discussion. Really welcome everybody's feedback and input. And thanks for being here.
Perfect. Well, so I have, thanks very much for the invitation to do this. It's something that I think is exceedingly interesting and hopefully a way we can really improve our outcomes for our patients. So at Duke, we use freehand interstitials with tandem and ovoids. And so that's kind of what I'm going to talk about, although I'm also going to talk a little bit about what the impetus for using a hybrid applicator is from the start. So I'll go through some of those data slides as well. And here we go. So I think, you know, when any of us think about using an MR-guided treatment plan, I think the EMBRACE study and the Vienna group prior to that has been one of the most influential groups presenting on that. And, you know, really the reason that we start to think about interstitials is that there's a clear dose response that's observed, particularly as we go to higher and higher stages and volumes of HRCTV, the more helpful it seems that an image-guided plan is. And I think maybe most saliently from these papers from 2016 from the retro EMBRACE is that as the HRCT volume goes up, that local control seems to go down, and we can compensate that by increasing the coverage as far as the D90 to the HRCTV. And this seems to be actually more prevalent or more striking the more locally advanced cancers that we have. And so as we go up in D90 dose, that particularly for stage 3 and 4s, that we can increase the local control percentages. In fact, for a D90 of greater than 95% for stage 3 or 4, that we can actually increase that to almost 90% if we get above 95 gray. This is less so for the earlier stage cancers, but still kind of exists. So there's an impetus to dose escalate based on D90 of the HRCTV as defined on MRI. Also, part of this paper was an observation that with IRCTV, that the dose, when increased the dose for your D90, that your local control also increased based on your IRCTV goals. And this is actually the first demonstration that IRCTVs, which is again the expansion of the HRCTV based on MRI, resulted in some sort of control variable. So I think, given these two observations, that dose matters, particularly based on MRI-based treatment plan. One of the emergent phenomenons, I don't think anyone goes into MR-based treatment planning and says, I want to start using needles. It's actually rather the inverse of that, where someone starts using an MRI and then starts to realize that they're not covering all of the disease in at least some portion of their patients. I love this paper from Folkdahl, which shows that they started their MRI guidance, and then as their cases increased, they started to increase the number of interstitial needles that they started using. And this was very much my experience at Duke, was that as I started to do more and more MRIs, I started to realize that a ovaloid alone was not covering a large portion of these cancers. And I've heard this over and over from multiple different providers, that they started using MRI and then suddenly they're like, oh, I need to start using more needles. For me, this is the exact case. So as one can see here, this is a lady with stage 2 cancer. But as you can see here, based on her MRI, she has this large posterior mass, and the tandem kind of falls a little bit more anterior within the case. And so as I tried to optimize her treatment, I couldn't treat it without expanding out into the bladder anteriorly. And we had some prostate flexi needles lying around the clinic, and I was like, why don't we throw some in and see if we can get better coverage out there? And I was very pleasantly surprised that with just a couple of dwells in these 2 straight needles that we placed, that we were really able to cover that posterior lesion and get off of the bladder and really get to an acceptable, MR guided dose. And I think that, as more and more centers have started to have experience with this, that this has sort of been seen across the board. This is another Embrace study paper, which shows that as one adds interstitial brachytherapy, that not only is your D90 better, and you have better coverage of your cancer, you actually see an increase in overall, in this case, it's local control, and at least borderline, but particularly for those with an HRCTV of greater than 30 cc's, that one sees a much more dramatic effect as far as the potential for local control. I'll pause at that second because you may need to remember that for some future question that may exist. So again, for 30 cc's of HRCTV, one might see an increase in local control. So this sort of naturally comes maybe a bit more frequently for patients that have more lateral disease. And in this case, one can see that even just adding 1 needle laterally here, that one can much better cover a lesion that was sort of borderline covered on prior fractions. So at Duke, when we started doing this, there was no good hybrid interstitial applicator from our manufacturer, meaning like a Vienna or an Utrecht or something like that. And so we started literally doing this all as a freehand. And what we sort of settled on, which we've sort of stuck with ever since, was doing these freehand needles. And at least our preference in our clinic is to use a titanium needle, which is just available from our manufacturer, which is Varian. I don't have any skin in that game. I think, obviously there are a lot of great manufacturers out there. But what we ended up doing was using these titanium needles. We pre-bent them by hand. One has to be careful with pre-bending these because one can bend them too much. Remember, there is a physical size of the source, and there is a point which you can bend it too much such that the source cannot actually traverse the lumen of the needle. And so we actually have, we found out by trial and error actually, that you can't bend these needles more than a 3 centimeter radius. It says minimum radius here, but that actually means that you can't bend it any further than that. Basically, when they do our source exchange, we were able to get actually a dummy source wire from the afterloader. So when they replace the source, they replace a dummy wire. We actually have them cut that and give them to us, which they're happy to do. And we can actually run these needles each time to make sure that that path is clear. Again, that was a trial and error issue where you can actually kink these needles such that you can't get a source through it. And so for our process, at least, we routinely will place the needles and then run those needles both at the time of prep and at the time of placement to make sure that we don't have this great plan and then realize we can't actually do it. The way I do this is usually place a needle driver on the end of the needle to the depth that I want, and then as I place them, I get the cervix, and then I literally place the needle where I want it to get to the point where the tips are against the surface of the cervix, and that sets my depth, basically. So we also have, we're fortunate, and I think this is something that should be fairly accessible, is where we have an ultrasound in the department that we have access to. And oftentimes what we'll do is we'll do a transabdominal ultrasound and actually be able to image these needles as we place them. And you can actually see them fairly well. In this case, that's obviously the uterus, the body of the uterus there. In this case, you can actually see 2 different needles we've placed into the cervix on that side, and we can sort of see what our depth is. In cases where we're not able to actually image them in real time on an ultrasound, we actually do have an Aero CT, which is a mobile CT unit that we can actually image patients in the lithotomy position in stirrups and actually image the patient without completely bringing their legs down and completely undraping them. I don't prefer to do this because it takes a long time and it's a lot of efforts to do this, and it does extend the procedures, but it is an option that's available. And I think in other settings, you may be able to do this in a CT. The problem is mostly, in most CTs, you're gonna have to bring the patient's legs down, et cetera. This isn't a perfect device, but we find it useful, at least in our practice. So again, this is just another example of using interstitial needles just to bring the dose off of the bladder in this case. In our unpublished data, we can see decreases in both bladder, rectum, and vagina in this case, and an increase in the 0.8 dose for what it is worth. Also of note for potential future questions you might see online, there is data from Embrace, in this case Retro Embrace, showing that as one actually pushes the dose further down as far as rectum, that with, let me see if I can share this actually so you can see it, where the 3-year toxicity rates, this is with grade 2 or 4 toxicity rates, if you could push that under 65 gray, you can get under a 10% toxicity rate for that sort of low to intermediate grade toxicity. But maybe most importantly, and again, particularly relevant for a particular question you might see later on, is that your fistula incidence actually goes way down as if you could push that to the 75 gray. So again, for lower toxicity, you can push it under 65. So that's sort of our stretch goal. But if we can really make it under 75, that really can push down the fistula incidence to under 2%. So that's a number to sort of remember for future. Again, if covering an HRCTV means that we exceed this, again, even if you exceed it, it's still a 12% in this case, is still fistula. A fistula is probably a better complication than uncontrolled cancer or uncured cancer. And so sometimes there's a balance to be made. However, again, if you can make 75, great. If you can make under 65, even better. I'm going to skip this vaginal toxicity because it's not really confirmed in other locations, but just for reference from some of the numbers I'll show, we've, at least in our experience, shown that a D2CC to the to the vagina in this case has resulted in a lower dose. So we do still contour this in all of our patients. But again, this is a work in progress. This is not something that I think most people do, for what it's worth. What we can find is that by loading the ring or in the intravaginal sources and even interstitial sources, that one can decrease the vaginal dose, and that probably can result in lower vaginal toxicity, for what it is worth. This is still sort of evolving data though. So to get to our case, this is a patient who actually was a fairly standard case. This is a patient with squamous cell carcinoma, 32 years of age. She had an exam showing a fibrous mass of the cervix. Biopsy was positive for squamous cell carcinoma. Bleeding was fairly controlled at the time. It should be said currently controlled. She was having moderate pain, but otherwise it was improving. On exam, had a 5 centimeter friable mass. So again, this is what in the current staging system we would call a 1B3. So greater than 4 centimeters, both on imaging and on exam. And this is her MRI at the time of diagnosis. So when you're looking at MRI, again, you see a fairly normal uterine body here. In this case, anteverted, as most cases are going to be. But what you really need to look at is on the T2 weighted is these gray zone. And you can see in this case that it's quite expansile onto the right-hand side, but you see this nice black line here, which is what at least I think of as the residual cervix or the vagina on that side. And what that says to me is that this isn't a 2B exam. This is on MRI at least. This is actually a 1B3 or a locally advanced organ confined cancer. So she underwent 45 gray with cisplatinum, and as one might expect, actually had a great response. A lot of these patients nowadays have an excellent response to chemoradiation. And we obtained an MRI actually both pre-brachy and at the time of brachytherapy. In this case, she had a great response. But I'll say with our experience over time, we may have gotten away with just a tandem ovoid in this case. But really, I've sort of evolved over time for this to sort of be my default, where I will actually put needles on both sides. And what I found is that by putting a needle on either side of the cervix is that I can actually shape the dose above the ovoids and push that dose out laterally and really shape it such that it's not expanding out into the bladder here or in the rectum. Our loading pattern, which I would encourage everyone to at least look at, if not be actively involved with, is, again, most of the activity is in the tandem. There is some activity in the ovoids here, and there's not that much activity in the needles either. In fact, I think this is only, again, the rule of thumb is to make your loading into your interstitial needles to be somewhere between 10 to 15%. This is very much in that. Again, you want most of your loading, if possible, to be in the tandem, because again, that's where your most radioresistant, your most hypoxic cells are going to be. That's really where you want most of your inhomogeneity to lie. And really you want the needles, in most cases at least, to sort of feather that dose out laterally a little bit. I'll say that sometimes we do exceed this rule of thumb of 10 to 15%. But when we do that, we always look back and say, like, well, was there some reason why? Did she have a big mass off to the upper left-hand side that it really made sense to put that up there? And if it makes sense, then I'm happy to do it. But I think it's always worth it to sort of gut check yourself and say, is there a reason why we're sort of exceeding that rule of thumb? Because rule of thumbs are great. They're not necessarily the end all and be all. So sometimes we do exceed that if it makes sense in that particular case. So again, we did a final EQD2 calculation with this patient, including the 45 gray of external beam. Our D90s were quite good. In fact, this is something we would sort of aim for even a more locally advanced cancer. We tracked D98s, and then our bladder dose, in retrospect, we probably could have pushed this down a little bit just to get below 80 gray, which is the current, embrace standard for the bladder. But rectum and sigmoid are well within our constraints of 65 gray. Bowel as well, although there's no great data between sigmoid and bowel for what it's worth. And again, our vaginal doses, generally speaking, we want to be somewhere beneath 108, 110 or so. And in this case, we've well got that. Now, sigmoid, bowel, and vagina, it's great if we can make those constraints that we sort of have, but again, if we exceed them, it doesn't keep me up at night. I think these are sort of more stretch goals more than a specific thing. So I have a second case, but I think in interest of time, I'll sort of save that in case we have time to go through it. And I guess I'll take any questions that anyone has at this point.
Junzo, we had a couple people asking about transrectal ultrasound as an image guidance technique. Have you ever tried that?
I've tried it once. I was not particularly happy with it. I think the problem, this could be the fact that I don't do prostate, so I'm not like really, I don't have my transrectal like technique maybe as finely tuned as people who do everything. I find that because the uterus kind of tilts anteriorly in most cases, that sometimes you sort of lose track of where those needles are, and you can actually pick them up on transabdominal. Now, you could do both, it's just that for me at least, transabdominal was something that first of all, you don't need to prep the rectum, and it's a little bit easier of a setup because literally you just do your implant as you normally do. You can backfill the bladder with 100 plus cc's of saline, and then you just look, and in most cases you're able to sort of see at least that you're in the apex. You can really see the fundus really well in that situation. And not, but I'd actually like to hear, do other people use transrectal, and what's their experience with that?
So Junzo, I would just comment super quick that I also see them perfectly fine on transabdominal, and I do prostate as well. And I personally don't find a reason to do transrectal because I feel confident and see them fine transabdominal.
Yeah, my experience is also very similar. I haven't been able to achieve something better with transrectal. One other question was about immobilizing the needles relative to the TNO. How do you do that, Junzo?
So I actually do not do any particular. So our process is to treat, is to place, plan, and treat all in the same day, and then everything comes out. We don't leave things overnight necessarily. So not in most situations. So we actually do this 4 or 5 times, depending on what dosimetry we get. I found that things don't really move so much in the vast majority of cases. So I don't actually do it. I do make little marks on the skin or on the, on the whatever is close at hand, so that I can kind of cross-reference where the needles are in relative to everything else. But usually when we're placing the needles, you can really feel it bite. I mean, the ideal thing is to feel it really bite into tissue. And if you get that, then it tends to stay in place really well.
Yep. Yeah. Let's let Scott take over the slides and ask one more question while we're doing that. Question is about needle-related hemorrhage. What's your experience with that?
Yeah, so this is something that happens every once in a while. I'd say, it's hard because I haven't seen any large series based on this. In my experience, it happens about 5% of the time, such that when you remove it, it's more than just the average, usually you see some bleeding for about a minute or so. Oftentimes you can tell fairly quickly whether it is a slow bleed or if it's a little bit more than average. I think you need to be prepared by doing this to pack the patient, potentially with Mon cells or, any like a hemostatic solution. And also at least have, I mean, we've only transferred out patients to the ED maybe once every 2 or 3 years it's happened, but it does happen. So I would have that plan in place. Usually what I find is it's patients who have, one of those big tumors that have a great response and they just have this cavity. And I get the sense that sometimes when you have that cavity, there's no real, you're placing the needles or even the tandem for that matter, and you just don't have that auto tamponade that you get from all that connective tissue that's close by, to sort of auto, keep everything in place. And so those are the cases that I find I'm a little bit more worried about a bleed for what it's worth. But I'd be prepared for it. Again, I've never had anyone have like a dramatic negative effect, but you do need to be prepared for it occasionally, like maybe 1 out of 20 cases will actually have to pack. But usually we leave the packing in for an hour, we look at it over time, and we pull it. If the packing is soaking despite all of that, we have occasionally transferred patients for inpatient care, but that's been the exception rather than the rule.
That's great. Thank you so much. Scott, you want to take it away?
Sure, I'll try and be quick so we have time for your slides and more questions. I'm going to go through 2 cases briefly and then talk a little bit more about, different applicators in performing the procedure. So this was a lady I saw recently who was originally stage 2B. Unlike the case Junzo presented that was a anteverted uterus, she was originally retroverted. So, here's pubic symphysis. Let me go over here. Here's pubic symphysis in the front, sacrum in the back, and here's tumor more on the posterior portion of the cervix with the retroverted uterus. Here's another image of the MRI, 2 different MRI sequences. She also went on to get cisplatin, 45 gray of external radiation, and here's her first fraction of HDR brachytherapy. Similar to the very first case in Junzo's slides, the tumor was more posteriorly located, and here you could see the tandem more anteriorly located. So if you're going to try and push dose posteriorly, you're either going to have to really dose the posterior, either ovoid or ring, high and increase vaginal dose and potentially rectal dose, or you're going to increase bladder dose substantially. My general practice is to treat the first fraction without needles and kind of see how things are and then add needles as needed. Here again is the first fraction. This now is in plane with the tandem, showing how anterior it is relative to this mass posteriorly. Here's what the first fraction of HDR looked like. You could see, we have our prescription dose, which is red or 6 gray, slightly going into the posterior bladder wall there. And we also can see that the vaginal dose, green here is the 200% isodose line. And the 200% isodose line was starting to touch or even creep into the vaginal tissue, which I try and avoid. But in this case, did it for the first fraction. You also could see that the prescription dose is starting to touch the rectal wall there. We could go through the D2CCs of all these OARs in a minute, but you can get a rough idea that you're going to be exceeding some of your targets just by looking at the isodose lines. Still, our coverage of this kind of posterior patient right tumor was suboptimal, and that's why we decided to add needles for subsequent fractions. I would just note that you can see the holes for the needles where they could be here because we're using the Venezia applicator, even in cases where we're not using the needles, which it's not everyone's practice, but it's kind of become our workhorse applicator. Here's the dwell times in the ring, the tandem, as well as this, tandem's down here, number 3, and the split ring applicator up here. These dwell times are way more than I'd like to see at a position in the ring, or it's kind of like ovoids because it's split ring, but we did it for the first fraction. Subsequently, we put needles in, 3 needles in that kind of arrangement, the 4 o'clock, 6 o'clock, 7 o'clock position, and that allowed us to move dose posteriorly while staying off of the bladder anteriorly, and also substantially decreasing vaginal dose. As you can see now, the even the 150 esodose line is within the ring and not going into vaginal tissue, whilst improving coverage of our target out here in this kind of posterior right direction. This was another, so that was the second fraction. This was the third fraction, showing, also similar outcome. As Junzo pointed out, our weightings in the needles is quite low. So here is tandem here, channel 3. And we had changed our source partway through this patient's treatment, but here's our dwell times in a fresh source in the tandem. Up here is the ring. And then here is the needles. You can see only 1.5 to 3 seconds dwell time, whereas tandem is in the 8 to 15 second range. This was her dosimetry EQD2. So you could see on that first fraction, our HRCTV coverage was okay, but not great. Whereas our bladder, rectum doses were getting a little bit higher than I'd like. Subsequently, we kept our HRCTV above 6 and kept our other OARs reasonable. Though, as Junzo pointed out, I shoot for 65 gray on rectum and sigmoid, but we accept over that if we need to ensure coverage of the target. So a few quick tips on incorporating it. I've presented this at the ABS meetings before, at least parts of this. This was another case just to give the same idea. We're not covering now in this case laterally where we would like to. If we increase our tandem weighting, it sends dose everywhere. If we increase our ring or our ovoid weighting, it increases vaginal dose. Whereas if we put needles in, we can preferentially shape the dose in the direction we want without increasing doses in other directions. Here's an example of that case. So there are options for every system. If you have an afterloader, you can do this. If you have a newer variant afterloader, you can get the plastic kind of ring and tandem set. This one is nice in that it's a smaller ring diameter and may be usable in more patients. If you have an older variant afterloader, you can get this one from MIC. This is the one I used to use before we switched to Elekta to get the Venezia. It is quite a bit wider. With the hybrid buildup cap, it's 36 millimeters diameter, which is not every patient can accommodate that. This is the Elekta solutions. Here's the Utrecht applicator, which is the tandem and ovoids. Here's the Vienna 1. Here's the Venezia. I won't go through all this in too much detail in the interest of time, but I would note that more frequently we're going to be using these lateral ones, not as often this anterior one due to bladder or ureter, and not as often this posterior one due to rectum or sigmoid, unless the tumor is really extending back that way. The Venezia 2 can treat up to 5 centimeters of vaginal extension, whereas other applicators, if there's vaginal extension, you may need to switch to a full interstitial implant. It's important to know how deep your needles are going. So this was with the Varian solution, but we would mark the needles. With the Elekta solution, they have these guide tubes, and you can mark the needle back here before you advance it within the guide tube. When you're doing the procedure with the Elekta solution, it's important to have the needle tip into the kind of ring portion of the applicator, but not all the way through. If you put it all the way through, you'll get vaginal lacerations. If you don't put it in or at least part way, you won't be able to advance it around the curve once the ring is in place. So you want the stylet and the needle kind of around the corner of the ring and into the applicator, but not through the other side. You want to label have some sort of convention for labeling, and then mark the needles on the outside of the patient, because if you just leave them hanging out, your physicist is not going to have fun trying to figure out which one to connect to. So labeling your needles is important. And then reconstruction is generally easier on CT than MRI, so I always get both and fuse them. When loading your needles, don't load them at the level of the ring or the ovoids, because that will increase vaginal dose, so only load them above the level of the ring or ovoids. That's something to watch for, because it's a nuance that not all the physicists are aware of, and it will increase dose to the vagina unnecessarily if you're loading it too far down. And then this is just an older example showing at the level of the ring, we're not loading it, only loading it towards the tip. And then as was mentioned, we shoot for 10 to 20% of the tandem weighting, which I always think of it in seconds. And if you take number 40 and divide by your source activity, so fresh source 10 curie, you might load it for 4 seconds at the tip, more like 2.5 seconds for the remainder of the needle. And then if it's an older source like 5 curie, it's more like 8 seconds and maybe 5 seconds. That's just a rule of thumb. Okay, so that's all I have. Any questions or?
What's your process for deciding exactly which needles to utilize and how far to advance them? How do you do that pre-planning step?
Oh, sure. So that's a great question. So like in this example where, let me find it. So in this example where I don't have needles in the first fraction, I'm looking at kind of a fraction where I would like to improve it and trying to find, which locations I would want dose to come from. And you can almost see on this kind of slice here, which is why I included it, that, there's a hole here, right here, where, I would expect to be able to contribute dose in that direction would be beneficial. And then I look in the sagittal plane here and measure, so I put this green line kind of where I would expect the needle to go if I put it in through one of those holes. And I just measure on the CT or MRI from the first fraction about how deep I would want it to go in order to be, correctly positioned, which is generally 2 to 3 centimeters. And then I try and see it on ultrasound, like we discussed. And then if I need to fine tune it slightly under CT guidance, once the patient is getting their CT scan, we can, move it in or out by 5 millimeters to a cm if needed. But usually we get it pretty close just by kind of estimating from their first fractions imaging and then watching it go in with ultrasound.
And I'll say that occasionally, even, best best plans, occasionally we'll see it go a little bit further than that. And in that case, we just pull it back a little bit. We'll do one CT. And then at that point, when you're getting the CT, it's much easier to pull things out than push things in, because oftentimes they're either recovered or recovering from anesthesia. So oftentimes I'll place it a little bit further if there's a question, and then I'll kind of I'll kind of back it out occasionally if it looks like that's an issue.
There's a question about sharp versus round needles. Thoughts on that? I mean, the ones that come with the applicators are reasonably sharp, so I only have experience with those.
Yeah, I was going to say the same thing. I can't imagine advancing a rounded off needle through tissue, so I've always used the sharp ones as well.
Yeah, ours is sharp. It's just, I think you're struggling against, oftentimes when you're actually putting it into a tumor, you're going to be pushing the tumor away from yourself if it doesn't have enough of a point to it. Now there is cutting versus pointed. I think ours does have a little bit of a cutting point, and that possibly could increase the risk of bleeding to some extent. But again, in our experience, the fact that we can actually place them where they need to be has always been more important for our case, at least.
Yep. Yeah, that's been my experience too. And the needles are within the cervix itself, as opposed to like a vaginal apex case where they wind up, in the peritoneal cavity. So I feel a little more comfortable with a sharp needle in that situation. All right, you guys see my slides okay?
You seem great.
Okay, great. So this is my case. This is a 46-year-old woman who presented with pelvic pain and bleeding. On exam, she had a large fixed mass really occupying her whole cervix and extending to the pelvic side wall on exam. A biopsy showed a squamous cell carcinoma. CT showed a 7-centimeter mass, which was confirmed on MRI and CT. Here's her PET scan. So you can see down here, this very sort of oblong mass within her cervix. And here's her MRI. So it was a very asymmetrical mass and very posteriorly protruding. And after 45 gray, unfortunately, it did not regress all that much. So she was a case that we thought would benefit from a hybrid applicator. And we have been using this Venetia. We primarily have used it in the configuration of with the tandem and the ring, and then these needles that pass through this ring are really a semilunar ovoid. We have not used to very much extent, I guess one case we did, but this perineal template or the intravaginal applicator. So we don't have as much experience with that. But have found it to be a good solution for cases like this, where there's just a lot of cervical disease, and especially where the cervical disease is asymmetrical, so that you really can't optimize a standard intercavitary applicator. And then this is the view of the applicator as you're looking at it from inferiorly, and it alternates straight needles with oblique needles. And so, as Dr. Glaser was saying, we put these tubes into these positions, and then you have to be careful to label them because it's not really clear after you've placed it which needle is correlated with which site within the ovoid. And so we label them 1A, 1B, 2A, 2B, like that. In terms of the workflow for how we've done the hybrid applicators, we do some sort of gestalt pre-planning based on this MRI that we typically get before the first implant, and do some rough measurements based on where we think the tandem will be and where we would roughly predict that a ring would be based on the relationships between the tandem and the needles. And so that's about 1.3 centimeters in that Venetia. So we make those measurements and kind of approximate and use that to start to think about which of the holes in the semilunar ovoid that we expect to utilize. And so we select those tubes and we attach them to the ring and we label them. So here's just an image shown of what that looks like. So here's the tube, which basically just designates that position as one that we're going to use. And then we do the tandem insertion with ultrasound guidance. The ring is secured. If you haven't used this Venetia before, it is a little bit tricky to get these semilunar ovoids attached to that tandem. And there's kind of like a little curlicue on the tandem, and so the ovoids have to slide into that little curlicue. So it's worth practicing a few times before you're in the OR. And that little curlicue thing can kind of disappear into the cervix, and so then it's hard to get it attached. So also helps to position the tandem so you can see the target there when you just get those ovoids secured. And then we, in our workflow, we do packing and imaging. And so we've done this both in CT and an MRI. And so what we've done is to image the patient without any needles advanced, and then kind of make a final decision about how far we want to advance them, and then repeat the imaging. And so this is an example of a case. This was this case where she had this really bulky posterior disease. Here's her imaging before we placed needles. And then there's her imaging after we placed these Venetia needles. And here's sort of the process that we've been using intraprocedurally. So making measurements and predicting, much like Scott was describing, from the applicator into the target. In this case, we use the oblique needles in addition to the straight needles. This is the setup that we use for MRI. So the patient is swung out to the periphery of the room. So we're working outside this 5 Gauss line for doing the procedure, and then the patient goes in for imaging. But we've used a similar process in a CT suite, which is definitely simpler since you don't have to think about making sure everything is MRI safe. And then this is just an image of the needle after placement. Here is a comparison of the plan that we made before we placed needles and then after we placed needles. And in this case, for keeping, so we're doing PDR, so essentially this is 1/2 of their brachy. We do typically 2 PDRs that deliver somewhere on the order of 20 to 25 gray to the high-risk CTV, with having the targets of getting our EQD2 over 87. And then protecting the bladder, rectum, and sigmoid doses to stay within those constraints that Dr. Chino talked about. So in this case, we made a comparison between what we did with the needles and what we did without the needles. We didn't treat the patient in this case without the needles, but we imaged and modeled what that plan looks like. And we were able to improve the high-risk CTV by 9.5 gray with the addition of those needles. And this is a comparison. These are 4 different patients who had needles placed. So in this upper left-hand corner, the patient had 5 needles for 5, 6, 7, 8, and then 4 in the others. And so you can see, first of all, that similar to what we talked about, the majority of the activity within the tandem. The black is the number of seconds, the relative dwell weights for the needles for what we treated, and then just as kind of a research study, we were comparing what we would come up with if we did an inverse planned approach. But either way, you do wind up with the majority of the activity in the tandem. We typically have about 10% of the activity in the needles, with some variation, as you can see here. Definitely the ones that are well situated right within tumor that are helping our cause the most can push a little bit more than that. And have done thinking about how to better predict where these needles will go. This is an applicator model that is available for Venetia, and trying to work on how to better predict where those needles will be, because it is not always, we've found, exactly where we most want them to be. So I think there's some opportunity there for improvement as well. But that is really what I have for my case. So we will go back to the question and answer and tackle as many questions as we can here.
Dr. Klopp, I'm curious, do you, when you place the needles that you didn't, well, when you decide kind of after the applicator's in which needles to place, do you have any trouble getting the needle through the applicator?
Well, no, they're all the way, we put them in exactly as you showed within the ovoid itself.
Oh, okay.
And
I just want to make.
Yeah, no, it's already secured in there. So when we put the ring in, they have those guide tubes in there with the needle. And
Okay.
then the part we decide is how far to advance it after we have the first set of imaging.
That makes sense.
But as you know, we have to commit to which holes we think we're going to want to use before we place the applicator in. So that part we have to decide just based on the pre-brachy imaging.
Okay. And I found when I place the needles kind of posteriorly, that takes away some of the need for packing. The needles almost act like a retractor, or the guide tubes, I should say, act almost like a retractor. But I've also found that if I try and place too many guide tubes, it gets a little bit too space occupying, and it seems like you have to be a little bit judicious in order to have everything fit in appropriately. I'm just curious if you have run into many situations where you want to place either more tubes or needles and have trouble with the patient's ability to accommodate all the equipment.
Yeah, I definitely have. I agree with you that that's a balancing act, because if you wanted to just leave all options open, you could put all those guide tubes in, but that becomes way too cumbersome to manage. So have to make some estimation on what we think we're most likely to want to use. And definitely have had situations where once we look at where it winds up, kind of wish we had another one available to use, or, so it is a nice thing about HDR that you get 5 options to do it.
Yeah, to perfect it on the reiterations, definitely.
Yeah, I see that as an advantage in that regard. But I mean, the nice thing about our PDRs is that if we do one really complicated implant, then we can, deliver a lot of the treatment with that insertion.
Yeah, I'll echo the idea of iterating, and it's oftentimes like our best implant is not our first implant. It maybe not even be our second implant. So oftentimes it's a work in progress, and we'll do up to 5 implants on patients oftentimes to get it to work. And then once we get, if on a single fraction, we're like, oh, this is perfect, then sometimes we'll ride that, source a little, that position a little bit higher than we otherwise would, just because we're like, we don't know when we're going to be back here. So let's go ahead and take that a little bit higher this time around. So I find it helpful.
Yeah. I mean, I've read about the centers in Europe which actually place the applicator, with kind of a trial run or dummy run, and then image it and then decide, kind of like taking it even a step further than Dr. Klopp does with, getting a MRI and deciding to actually put the applicator in.
Yeah.
I've seen or heard of that done. I kind of like your idea of Dr. Klopp of, estimating where you think you might need them on the first day, but not advancing.
Yeah.
Then there's kind of the way I do it, which is accept one fraction that's suboptimal and then try and make it better the next 4.
Yeah. We're fortunate in that we do have an MRI in the department, so we're able to sort of get them with a minimal hurdle to get through. So we will get a pre-brachy MRI, and it's not strictly necessary, but it does sort of help me realize, okay, well, this patient has something that's way back posteriorly in the left-hand side. I'm going to want to try and get a needle way back there, and I do my best, and then it's an iterative process over time. So.
Yep. So looking at some other questions, do we report point doses, both rectovaginal and vaginal dose?
So we do. We track not the rectovaginal dose, but we do track the D2CCs. I sort of flipped by that slide fairly quickly. I'll say that right now, broadly speaking, RV point doses do seem to be associated with vaginal toxicity. In our experience, we have seen an association of vaginal D2CCs with it as contoured of just the vagina, not including the cervix. So it kind of is it's kind of a weird looking contour because it's just the surface. It's a 5 millimeter fixed brush. I'll say that we're probably the only center that I know that does it routinely. We, if nothing else, is a surrogate for reducing the dose to the vagina. And I think the more people do this, and I saw from everyone else's implants that, we're pushing more dose out into the cervix itself and away from the vagina. That actually helps all of our doses to both rectum and bladder. I don't know if we have a final answer as to what the right thing to do of all of that is, but I certainly think that if there's an option to reduce the dose to the vagina, it's probably worth doing. Unfortunately, it's a really understudied question of vaginal and sexual toxicity after brachytherapy, I think it's really maybe the next frontier as to what we're going to hopefully be accomplishing with our patients in the future. I think interstitial is going to be part and parcel, though, for achieving that.
Do you find that adding needles reduces your vaginal doses? Vaginal surface dose?
It does, yeah, it does a lot, because a lot of times, if you have like let's say an upper lateral cancer that kind of goes a little bit further out onto the side, there's no other option. Either you increase your tandem dose, which then increases your rectal or vaginal dose, which are clearly associated with toxicity nowadays, or we increase our ovoid activity, which increases our vaginal dose more than anything else. So I think that it really does help us move the dose out of the vaginal sources. Now, on the other hand, I don't want to completely unload the vaginal sources. I don't want to do this and then suddenly find a bunch of vaginal recurrences. So I still load, even in the best situation where I'm like, I can get this all done with a tandem only, or just a needle. I still load the ovoids to some extent because I don't want to find out in 2 years' time that I have a bunch of vaginal recurrences. So I always load them to some extent, but I do try to push as much activity out of the vaginal sources as I can.
And what's your dose constraint you use for the vagina?
So we use a D2CC of 110 or 108, our data was for 108, but we just rounded out to 110 for D2CCs, but that's sort of its own thing. I don't know how reproducible that is because I haven't seen other people reproduce it as of yet. So.
Yeah, so I agree with everything Dr. Chino said. I would add that, the published data from Embrace is more the rectovaginal point and not the volumetric. And I think it's really interesting work, but I personally haven't incorporated any volumetric. I just watch the isodose lines and I don't record it. But, in this case, you could see green is like the 150 and it's not going into the vagina, at least laterally, even with the needle in place. So I shoot for keeping it under 150, but if I need to, I let the 200 touch the edge of the applicator. And that's how I've just tried to monitor it or manage it, is just by watching isodose lines rather than some sort of specific point, because I think that's hard to quantify when, like on this patient, maybe the rectovaginal dose, point dose would have been fine. But if you're pushing dose just in one direction, you're getting your isodose lines going into tissue that you don't want that to be replicated, or you don't want to do that too often. So I watch the isodose lines closely.
There was a question about if you do needles for one, then you may not need them for the subsequent implants if they have a great response and your dosimetry looks good. And absolutely agree with that. I think that is something that is an advantage to looking with imaging at every implant and just see how your dosimetry is. If you're achieving your goals without the needles, then I think perhaps you don't need them for all your implants. But I like the idea of having them as an option.
Yeah, I mean, our practice is to put them in from the start, just because over time, and also because we're a training institution, I want residents to get used to like placing needles and not be too afraid of them, and so that's part of, I don't know if I would do quite as many as I do if I wasn't in a training institution, just to sort of show people that it's not something to be too scared of. Yeah, there are certainly cases where we'll, more often than not, we use them a little bit, but, there are definitely cases where I'm like, clearly we don't need it. Let's just do a tandem and ovoid. It does shortens the procedure a little bit, at least.
What do you both use for Smith sleeve versus no Smith sleeve? That was one of the questions.
I've never used them, so I don't.
Yeah. I'll say I've never used a Smith sleeve either. I've only seen them in other talks, really. I think that they're useful. I do think that they may make it difficult to place needles, but I don't know for sure about that because I don't know how big they are and how it would probably be difficult for our situation, because oftentimes what we're doing is we're, if that's the cervix, we're going just lateral to the cervix and we're pushing out laterally, and that's probably where the hub of the Smith sleeve would be. But for the more templated approaches like the Venezia or the classic Vienna or whatever, then your template is going to be in the rings or whatever, and that might actually be a little bit more lateral, and you might still be able to do that despite a Smith sleeve or not. So, but yeah, our Genoncs never put them in, so we never got used to using them.
So I use them in training at Pittsburgh. I would say if you're using this Vienna 1 applicator, the diameter of the tandem is actually quite a bit bigger than this, like the new Venezia applicator, or when I used this Varian solution, that's a pretty skinny tandem. I thought that the Smith sleeve did help to some degree when doing the procedure on the Vienna 1, which is the thicker tandem. I also think it makes a difference in terms of what degree of anesthesia the patient's getting. If you're trying to do it in office with lighter sedation, Smith sleeve is helpful. Whereas if you're going to the OR and have deeper sedation, it's probably of little benefit. So I don't put them in too often now, but on a challenging case, if I've had real difficulty with tandem placement, then I may put one in to make it easier on subsequent fractions.
Well, it looks like it's 4 o'clock. Do we have any last questions? Anybody, you want to pick up any of those last ones?
There's a question about what anesthesia that we use. So we're actually able to get by with conscious sedation or MAC, but I'll admit that and we do have an anesthesiologist come down for them. We're lucky in that, and they push, conscious anesthesia or MAC pretty far. So it is very helpful. It would be hard to do this with just some oral sedation because it's hard to predict how uncomfortable these are going to be. Some people don't seem to have much difficulty with it. Other people, it's really hard. So I think some sort of more active anesthesia care is necessary for a lot of these cases, but I don't know what everyone else does in these sorts of situations.
We really routinely do. I mean, most of our patients get intubated or have an LMA or get full anesthesia. Occasionally we do MAC, but really not for our interstitial cases. which I think is nice because it just gives you one less thing to worry about.
Yeah, sometimes we do have to wait for them to get a little bit deeper on the Mac, you know, and then it's fine, you know. Again, like it was a great study from Vienna about PTSD after these kinds of treatments, and it wasn't so much the procedure itself that was the issue. It was actually staying in the house overnight that was the more traumatic experience sometimes. And so, at least in our experience, MAC has been okay. Even actually, we've done SIADs with MAC, and it's been okay. But the amnestic portion of things, I think, is pretty helpful. It's pretty important, I think. So.
Yeah. Scott, any last comments?
No, I think my anesthesia practice is a little closer to yours, but I would like to have the option to do more of these in the office for workflow reasons and scheduling reasons, but I currently go to the OR for most of them.
Yeah, it's so interesting, all the different solutions. Well, I think this was fabulous. I learned so much. So thank you guys for joining us, and thanks everybody for asking such great questions and for being here.
Thanks, guys.
All right.
Thank you, everybody.
Bye, everyone.